Good morning, ladies and gentlemen. I would like to welcome you to this 24th edition of the Prague workshop, which we call now Prague Rhythm. On behalf of my co-director and all my colleagues from Prague, from both centers, which organized this meeting for many years. This year is very important for us because it marks the 30th anniversary of the first RF ablation in the Czech Republic. And that was done in IKEM in 92. And you see original recording from that first case. You recognize that it's a pre-excitation, and the arrow marks the first beat without pre-excitation. And this is Cynthia Tracy from Washington, and she was helping at that time with Jan Bitešník and Jan Janoušek from Pediatric Center. So this is Cynthia Tracy, please. And you see that recording here, and this is first beat without pre-excitation. And another important year is 94, when the first registry was presented in Olomouc, and that was the first symposium on arrhythmias and pacing. And we have probably the oldest and most comprehensive registry of ablations in the world, because since 94, we are continuously running this registry, and now we are negotiating that it may be linked with state statistical department, and we can get also data from insurance companies, so we can also analyze mortality and morbidity. This was a humble origin. As you can see, in the 90s, we had only 2 centers for adults and 2 pediatric centers, a small number of patients. But 97 was a very important year because we bought in IKEM first Pruka system, and then some other centers did the same. And you see that the numbers increased significantly, and these are the first centers that did ablations at that period. And we started education, and we also came with the idea to organize a workshop. And the first workshop was done in 98. And initially, we planned to use it for Czech physicians mainly, but even first year, we had about 35 people from countries around, like Poland, Finland, and other, Hungary, Slovakia, obviously. And next year was already a success, and we had 2/3 of people from international environment. In 2008, we initiated, thanks to my co-chair, we initiated cooperation with Homolka Hospital, which is the second large center in Prague. And since then, we do it together. And you all, at least everybody who attended the meeting, know that the atmosphere is very friendly in both sides. You see, that was from Homolka, this is from IKEM. And
it's more serious.
And we in the meantime, Czech Republic became really or plays a big role in the field of catheter ablations. This is from the latest version of a White Book of ERA. You see that Czech Republic was, I think, on the among first 5 countries in numbers per million. And not only numbers, but also new technologies and new strategies. And these are a few examples how we influence the development of technologies, like we did first in human ablation with a smart touch, and we published later. We were involved in 2 our centers and 1 center in Brno. We were involved in Diamond Temp, and this is a randomized study which was published recently. Both centers, again, especially Homolka, were involved in development of pulse field ablation technology with Farapulse. And also now with Afera, you will see today and tomorrow these cases, and you will enjoy how it works to see it in real life. And we have some preliminary data from Czech registry in 2021. We have today 25 centers in the Czech Republic, and 23 are for adults. And you see that they are evenly distributed. Of course, the highest concentration is in the capital, in Prague, and also in Brno, which is like second capital in the eastern part of the country. The number of ablations dropped a little bit in 2020 from 8,000 to below 8,000, but last year we did the highest number, which is 8,183 procedures, which is approximately 820 per million of inhabitants. And these are centers. You see that we have 2 high-volume centers in Prague, and then the numbers go down. But quite many centers do more than 200 ablations, which is, I think, very good for quality of care. If you look at this breakdown, it's interesting that in Homolka they do much more AFib than we do, where we do more VTs. We are the biggest center for VT ablation, especially for structural heart disease. We do also AV nodal ablation, and that's not because we don't know what to do else, but because we are a big transplant center and we have a lot of patients with advanced heart failure with CRT, and they do develop AFib, and we have to do AV nodal ablation. And we also are largest center for cardio-neuroablation. That's the other indications, and also do some combined procedures. This is the latest statistics from ESC, and you see that on left panel, although we are not the wealthiest country in the European Union, we are far behind Norway, Germany, Luxembourg, Netherlands. If you look on the right panel, ablations are on this one. So we are again among 5 countries in the numbers of ablations and ICDs and pacemakers. It's, in all these entities we are among the first. So there is a lot of work behind. And I would like to emphasize this, especially for younger colleagues, because many of them were even not born when we started with ablations. And I just wanted to recapitulate this journey for you briefly. So don't forget also to visit some sites in Prague. You probably will not see such empty places because this was taken during outbreak of COVID, so there were no people on Charles Bridge, but today it will be definitely much more. And I would like to invite you for next year, because we will celebrate 25th anniversary of this workshop, and we plan to do probably bigger meeting than today. So thank you very much for your attention. Thank you for coming, and I will give now word to Peter to say something also to welcome you. Because he is my co-director.
It's danger. Thanks, Pepa. I don't know how to name him, because I name him Pepa, Pepo, and Josef is like a little bit international. So we are really good friends, and I really appreciate that you saw that all the results about the ablation workshop, it's results about our friendship. I remember one session we got divorced by some chair that we were fighting about the VT support or no support, right? But we are really good friends, and actually I think that pronounced in the cooperation, and it's a lot of studies we are doing together, and actually I think it's very, very important to keep the international, cooperation, friendship, I would say friendship more than cooperation. And actually I think this is a result of this year. I believe that it's really first year we really can break all this COVID situation. Despite all the situation in Ukraine, I am very hopeful that it will be improved, and it will win the brains and not the devils. Okay, so I'm sorry to mention it, but I really need to, because I really feel very sensitive about that situation. And despite this situation, we really keep the science ahead. So thank for coming. Thank you for all these attendees. And please be a lot of, I really expect a lot of interactions and be very open. Actually, we are a little bit similar now with AFI meeting, because AFI meeting, we copied our strategy, how to show the live cases here. Okay, so we have always more live cases than others, but actually AFI meeting a little bit learned a lot from this, and I think that, for example, it's much energized now by showing maybe like in 3 days like 15, 16 cases every year, and I think all the live cases really energize, and the interaction is very important for us. So enjoy the meeting, enjoy the day, and not 3 days, right? So I think and actually party will be interesting. And I will expect you all in the party, and we can celebrate the improvements of not only ablations. Okay, thank you for coming. Thank you.
So now, ladies and gentlemen, I will ask Lukáš Klánský to have some musical introduction for this meeting. Lukáš is one of the young piano players in Czech Republic, and he will show you his art. Please. Good morning.
Good morning, ladies and gentlemen. I decided to play for you several pieces, 3 pieces by Frédéric Chopin, a Polish composer who was mostly living in France in the first half of 19th century. And I think to choose Chopin for this occasion could be seen somehow inappropriate, because to play Chopin correctly, you need to play a little bit arrhythmical. But on the other hand, I hope that Chopin's music will touch your heart. Maybe you was wondering why I don't use this acoustical piano, why I play this electric one. It's because this piece is quite old. It's probably made like at the end of 19th century or beginning of 20th. And this is not possible to tune anymore, because if you try to tune it, as you move with the strings, there is a big risk that all the metal part could be destroyed. So it's not really possible to use it seriously, but it's very interesting, like a historical view. So now for like a finish of my performance here, I will choose a very short piece. It's one piece by Ludwig van Beethoven. It's from his Variations, Opus 34. This is variation number 1. It has like 1 minute, because, you know, good music should be mostly short. And so I will play this very short piece on this electrical one, which is, it's fine. It's good for, you can move it easily. It never gets out of tune. It's some kind of, I don't know, Heineken or McDonald's or something. You definitely know what's it. But it can be interesting to listen also to this old one. And you can compare the sound, which will be absolutely out of tune, but it has some nice atmosphere. So I hope you will enjoy both. I will play first the Heineken and then this.
Lukáš Klánský. So we will continue with our program. So since Joris Ektor, who is a Belgian electrophysiologist who has a very nice anatomical lecture with 3D glasses, and we enjoyed a couple of years ago this talk, is not able to come today. I decided to replace him with my presentation about intracardiac echocardiography, kind of tutorial for electrophysiologists, because still many people don't use intracardiac echo, and I would like to fill this gap somehow and show you what you can see with intracardiac echo during procedures, both for atrial fibrillation ablation and for VT ablation. I just cannot now find the mouse. Okay. So I rather check again. So it's the most practical online imaging, no doubt. Of course, you heard about MRI online imaging, but this is, you see left veins, you see the ridge in between appendage. If you rotate counterclockwise, you see papillary muscles, maybe some scars on the papillary muscles. Very practical. Of course, you can use mechanical ultrasound tip catheter. This is pulmonary vein with the shadow of the catheter. And here is in better contact, but you see from this nice example that it's not the same like phased array. And phased array, we have at least 2 different vendors today, and they provide both very similar images, which is like longitudinal TE probe. Of course, you can also use a sensor-equipped ICE catheter, and you can draw contours of the chamber of interest, and you can have a map without entering the chamber, but it's used less probably than conventional 2D intracardiac echo. Some people tell me always, you need another person for this, you need special training, and it's not the case. I mean, it's very simple logistics. You put it through the left femoral vein as we do, and you have echo here, and you just do your manipulation. And we have some protocols for AFib ablation and for VT ablation. And we start with a home position. If you enter right atrium and you show a tricuspid valve, because you can get always disorientation, it's a home position, then you can check for effusion at the beginning of case, just going into the right ventricle and rotating to the right or clockwise. And then you can see also aortic valve in short axis, and you can overview appendage. And then if you just go to the right atrium and clockwise rotate, you see all structures on the way. That's what you need for AFib ablation. And then again, you check for effusion. So this is example of a home position. You go into the right atrium, into the middle portion, and then you see tricuspid valve, aortic root, and cavo-tricuspid isthmus, and that's a home position. And here you see how you are cutting these important structures. This is like an aerial photograph of the heart. And from the right atrium, you can overview all these structures. If you rotate counterclockwise, you can see right appendage, and you can see also crista terminalis. So this is a home position. If you lose your way, you can always find the way home. And then you can overview nicely the anatomy of cavo-tricuspid isthmus. You see sometimes it's quite mobile, and sometimes there is prominent eustachian ridge, sometimes it's a long one and with a lot of trabeculations. So every patient is different. Like everybody has different shape of nose and size of nose. So everybody has different shape and size of the isthmus. This is one of the worst anatomies, so a very hypermobile isthmus, where you have to stabilize the tissue. This one is, on the contrary, a lazy one, very simple to ablate for almost everybody. You can measure also the length. If you rotate counterclockwise, you see the appendage. So here you see atrial lead attachment, and there is a thrombus, smoke-like echoes, which are predisposition for thrombus formation. And obviously, you rotate more counterclockwise, you see crista terminalis, and that's a borderline between the posterior and anterior portion of the atrium, you can place the catheter around the crista based on the ICE image. If you go back to this home position and rotate slightly clockwise, you see aortic root, and here is his bundle area, so you can navigate your catheter without signals. You get to his position. Here you see even a left main, and this is obviously pulmonic valve, which is higher than aortic one. This is in young patients, so very steep heart, so you can see all these details. But you can see a lot of details even in older patients, obviously. This is, if you rotate slightly more clockwise, you cut the right ventricular outflow tract. Here you see the catheter in that typical position where we do most of ablations for RVOT, tachycardias, and septal left area. And if we rotate slightly more, we can see mitral valve. Sometimes it's not that visible, but you can also check if there is, for instance, vegetation, or we use it sometimes in patients with prosthesis. If there is a suspicion for infective endocarditis, you can go from the other side so you don't have shadow of the prosthesis. And this was example of appendage, and here you see again appendage. It's not the best position or projection to see or exclude the thrombi. I will show you some more later. Then this is our main interest for transeptal puncture, obviously. If you rotate slightly more clockwise, you see fossa ovalis, again, different shape, different size, and you can do transeptal puncture not only safely, but you can do selective puncture. You can do puncture where you want to do. If you go for pulmonary veins, you rather go more posterior against the veins. If you want to go for appendage closure, you do different puncture. If you go for a ventricle, you do different puncture. Left-sided veins are even more clockwise. You have inferior one and superior one. You can use also Doppler if you are not sure what is a vein and what is appendage. And obviously, you can measure velocities. And if you rotate slightly more, you get posterior wall, and you see esophagus. This is the same patient, so you see esophagus can move. It's not static structure. Somebody believes that if you can have a CT scan and then you mark the esophagus, it's always there. It's not the case. And you see sometimes it's a quite thin wall. And then you rotate more, and you cut in a short axis right pulmonary veins, superior, inferior, because they are like this. And if you want to see them more in longitudinal view, you have to decline a little bit the catheter, and you see right inferior with early branching, and you see right superior. There is always pulmonary artery next to it. So sometimes there is third vein, or even fourth vein, so you can see all these details. This is a view of aorta in cross-sectional, and there is appendage here, and this is a ridge between appendage and left veins. Here the left veins are very broad, but sometimes it's just a few millimeters away from posterior wall, so you see all these details. So this is the ridge I'm talking about. You see here, appendage, left veins, and the ridge in between, and you see it quite nicely. And again, anatomy is very different. In some patients, it's very floppy, thin. In some patients, it's very thick and does not move. And you can see if you are doing ablation in this proximal part of the pulmonary vein from inside, you see there is no contact here, and there is very nice contact here. So without contact force catheter, you can nicely see if you have contact and where you are, and you understand the whole anatomy. So these were a few examples for AFib ablation, but for VT ablation, again, we always check for effusion, and then depending on region of interest, you go either to right ventricle, you can go even to the left atrium and left ventricle, but that's not usually used, and there is no need for that in most of the cases. But you can go to the right ventricle and then a clockwise rotation, and you overview all structures in right and left ventricle. And then finally, we check again for effusion. So this is a basic right ventricle view. If you enter the right ventricle, you see moderator band, and you see papillary muscles. And this is another example from, it was given to me by Shiv Kumar when he was here. It's a nice case of arrhythmias originating from the moderator band, and they have some typical ECG. And again, with intracardiac echo, you can ablate not only effectively, but also safely. This is one of our cases. Was a lady with a lot of EPBs and repetitive VTs, and this typical morphology, and you see that you can check contact. As you can see here, there's no good contact, and there is good contact with simultaneous movement of the catheter with the structure of the heart. We can also use, this is from Fermin Garcia, who is here with us, and he uses a lot cartel sound, so you can draw contours of the structure. This is also useful for ablation below his bundle, where you have to hook the catheter below the septal leaflet of the tricuspid valve, like this, and you really ablate very close to his bundle, and you are separated from AV node by fibroskeleton. This is a typical ECG of that arrhythmia, and this is example from in real time. So you can put the catheter really up to here, or you can pull it towards the valve and ablate around this membranous part of the septum if there is a focus. If you rotate more clockwise from right, you start to see left ventricle, and then you can appreciate papillary muscles. Here you see, if you over-rotate more, you see anterior or anterolateral papillary muscle, usually two heads, sometimes quite big, sometimes it's very small, almost rudimental. So again, different shape, different size. Sometimes you can see ugly things like this, these two old thrombi. It was given to me by Dan Wichterle, who is also with us here, and he was able to ablate in between these two thrombi effectively. This is another example of old thrombus in apex, which was not seen because of calcifications. It was not seen on echo, even with contrast, but you see it on CT, and you see it here very nicely on intracardiac echo. It's very useful to ablate in aortic root, because you can see all individual cusps, and you can go from one commissure to another, basically millimeter by millimeter. This is right, left, non-coronary, and you can not only you can map carefully, but you can also pinpoint the commissure, like here with this maneuver. You see that the catheter is hooked exactly in the commissure here, and then you can ablate. No need for coronary angiography, of course. This is, again, detail of aortic valve in some patient with structural heart disease. You see the left main here, and you see the structure of the valve. You can also, if you rotate slightly more, you can see besides the valve, you see also outflow tract of the right ventricle and pulmonic valve, and you see the extensions of myocardium into the pulmonary artery, and sometimes you need to do this loop and ablate above the valve, and you can do it again safely and effectively with guidance of intracardiac echo. And you see the intimate contact of the right ventricle and outflow tract and pulmonary valve with aortic root. And here you see the shadow of the catheter in the right cusp, and then the tip is in the commissure here. Again, extensions of myocardium. This is reality, and often the ablation is done below the valve, but you can change the exit, and you have to ablate more to get rid of the focus, but you can go also above and ablate directly here. And some people, there's a group in China, they do 80% or almost 90% of ablations of these arrhythmias from above, because they are mostly in these extensions, not below the valve, but above the valve. And you see, of course, coronary artery around, so you can avoid ablating on coronary artery. So these are few examples how it helps you, and this is what I said, that this was the best pace map, but ablating here changed the morphology. You had to do ablation like line, or the other way would be to go above the valve. And you see here that there is extension, and the catheter is just jumping on the valve. This is another example of location in posterior outflow tract, aorta, and there is an outflow tract of the right ventricle, and this is corresponding site. You can also see arrhythmogenic substrate in the patients with structural heart disease. You can see if there is a septal scar or thinning of the wall here. You see here quite large scar on lateral free wall. And you can correlate this. Here you see purely epicardial substrate. You can correlate that with your map, electroanatomical map, or you can correlate with other imaging, but there is no need for other imaging if you have this online imaging. You know, it shows you reality. So this is a corresponding electroanatomical map with thousands of points. Looks very nice, but this is reality. So you can imagine that you do not map with this catheter, this area, you know, you just scratch the surface. And this is virtual reality, and this is reality. So it helps you to understand. We also do patients with LVAD, and then you have sometimes difficulty to map this area around the pump because of interference. And also you have to take care not to enter the inflow cannula because you can damage the system. So again, echo helps you to do both mapping and ablation. And also you can assist with a placement of impella if you need impella or some other percutaneous support to do ablation. We use it also for a left atrial appendage closure. Peter Peichel is expert in our center, and again, you have a couple of views where you can use for appendage overview. It's I showed you already this short axis aortic root LAA area. Then you can go to AP, to pulmonary artery. And you can go to coronary sinus, and you can go also transeptally, and you can see directly. So here you see some examples. This is from right atrium, obviously. This is close to aortic. This is like aortic root. Here is appendage. Here is left vein, and this is from pulmonary artery. So you see very close area, and here you can go directly to the left. Atrium and to pulmonary vein, and you see very close proximity to the appendage. So all of these details can be seen with intracardiac echo. There is no restriction if you really go to that chamber of interest. There are also some important things about safety. You can see hemodynamics to some extent. If you have ventricular tachycardia, this is on impella, you see the blood is basically stopping to move. And if you have hypotension, you immediately recognize if there is a fusion or hemopericardium, or if there is some pump problem, or if there is, for instance, air embolism. You can also avoid POP if you see this whitening of the tissue. You are heating close to 100 degrees. If you continue, you can have this crater, you have blast, and you can perforate the heart. So this is also what can be used by viewing, and this was one of our early cases of AFib ablation. You see big thrombus from the sheath, and since then we always do heparin at the very beginning of the procedure to avoid these catastrophic, potentially catastrophic scenarios. You can also see small thrombi on the other catheter, like Lasso catheter. So you can avoid this, and intracardiac echo actually was the strategy that helped to really realize that we have to do anticoagulation during the procedure to 350 seconds, because before that we used 250. I did many ablations historically on 250, and we were happy, and we said, okay, there are no embolic events, but maybe there were many embolic events, but they were just silent. So I mentioned if you have, for instance, hypotension, but even if you don't have hypotension or you see something like this, you know that you have to take out your tamponade box, take out the needle and do drainage before you have a drop of blood pressure. And if you see here, again, so you do not wait until you have a catastrophic scenario. Just to document how it can help, I will finish here. It was a male who was indicated for ablation for dysfunction, posterior hypokinesis, normal coronaries, but he had probably some myocarditis historically, and this patient had recurrent therapies from ICD. And you see already there are two morphologies, and you see here there's a large scar on, let's say, lateral area, posterolateral area of the ventricle, thinning of the wall, and you see these different morphologies of VT. We started mapping endocardial. You see quite large voltage, but these are areas of let's say low potential or late potentials. Even though there was, it was just sort of subendocardial scar probably in that region. We did ablation of these late potentials, and then we realized that there is a hemopericardium. So we did the drainage, reverted the heparin, and then after stopping bleeding, we finished mapping epicardial surface of the left ventricle. You see large scar here, and these are late potentials, much more extensive than endocardially. We did successful ablation, and patient went to the ward without any problem. So this would not be possible, I'm sure, if you don't have this close monitoring during the case, and you probably will not continue with this mapping. So I think in the interest of time, I will stop here. And if you have any questions, I'm happy to answer.
Actually, I think that it was very interesting and very important talk as an opening talk for this workshop. Do you have time, Peppa? We are a little bit over time. Okay. So before somebody has a question, so I think it's very important I like the last slide when you put the aspects why we are not using that. Okay. Randomized trials. Okay. Another operator and price. I think most of the problem is the pricing in Europe. If you compare Europe and US, and we have a guys from US here, and actually without eyes in US, I would say that I wouldn't be done any single procedure. If I'm wrong, they can correct me. And I think it's going more and more like floorless. This is another aspect we really need to figure out that it's very, very important for us. And then I like the comment about the the tamponade or tamponade, if it's tamponade or effusion like pericardium, because you are clearly advancing the action before the crisis coming. So really, I mean, the separation of the pericardium indicates clearly, I mean, the critical situation before the blood pressure drops, and you can react easily. So I would say that it's really, for me, very, very important aspect to really spend more time to trust the people, to invest the money, to make it cheaper or whatever feasible, to really spread the system, spread the method to all. And actually, on top of that, I would say that, and even you didn't discuss anything about three-dimensional eyes, because with three-dimensional, the system named Nuvera, but it was now bought by Biosense. So 3D eyes, it's here, and actually 3D eyes, it's clearly even more advanced, more helpful for all this guidance.
I saw 3D eyes. It's lovely, but it will be more costly. So now our mission is to get people used to 2D echo at least, and then we can go to higher level. But you are right. All these things are right and correct, and I think echo is very important, and we should really fight for using echo. I would sacrifice all my multi-polar catheters for ablation if I can buy echo, and the price is more or less similar. So it's not all about price. It's about willingness, about belief. If you have experience and you believe and you have all data showing that you can be more successful and more safe, then you start to think differently. And I think that's our mission to change the environment. And I think Eastern Europe is actually much better in use of intracardiac echo than many countries west of Czech Republic.
Any questions, guys? Comments?
I think it was pretty clear.
Okay, fantastic. Okay, so Pepo, thank you very much. Okay.
Now we have a short review of cases from the previous year.
Who will be the first, you or?
No.
It will be first, okay?
Okay,
fine.
so we have Milan Babic, who is our fellow from Serbia. He will show you some cases what we did last year during the workshop.
Good morning, ladies and gentlemen. I'm one of the ICAM fellows, and I'm very grateful to the Professor Kautzner on this my months here and the opportunity to present these cases to you. Because of the time constraints, we must go fast through the presentation without getting into too much the details. Many people had already seen the live cases and the videos that exist on the YouTube afterwards, so they know the details. And for the other, I can strongly recommend to see these videos that exist on the YouTube for all cases. The first cases was anatomically guided cardiac neuroablation for the recurrent reflex syncope. It was performed by the Dr. Wichterle, and it was young, otherwise healthy patient. The ECG and the echo were normal. This was a baseline ECG, also normal, and atropine test was positive. Here we can see the impressive sinus arrest pose that was documented on the memory of implantable loop recorder. So the patient was scheduled to the procedure. The procedure was navigated by the extracardiac vagal nerve stimulation using the Pahon stimulator, and the vagal nerve was stimulated by decapolar catheter that was introduced in both jugular veins at the level of jugular foramen. At baseline, we see the massive response of sinus node. It is a big sinus arrest, and also the massive response of the AV node. We have AV block. This is the map during the procedure. It was map of the right and the left atrium. The phrenic nerve was tagged because of the safety. And also there was activation map of sinus node. Sinus node was denervated using ablation of the right atrial GPs from both atria. And the pyramidal lesion set was done at posterior septum in order to denervate AV node. However, the final effect was achieved and demonstrated after the ablation in the vestibulum of the anterior vestibulum of the right veins. And after this procedure, in the follow-up time, there was no recurrence of syncope, not even bradycardic episodes. The second case is PVI case with the technology of cryoballoon. It was performed by Dr. Chihak. There is nothing extraordinary in this history of patient, and also ECG on admission was unremarkable. For the purpose of the workshop, it was acquired the CT scan and it was merged into on a CARTO system. And here we can see, here we can see that the procedure was navigated by the eyes. No contrast were required. We can see that all veins were isolated at the end of the procedure. We have parameters of the ablation, and also here is visible the phenomenon of the eye storm. From the ECM experience, it is a good prognostic sign, and where is good prognostic sign, there is a good follow-up time, no recurrence of atrial fibrillation. After that, the third case is bipolar ablation. It was performed by Dr. Peichel and Fatima. It was 67 years old with a patient with diabetes and non-ischemic cardiomyopathy that was mediated by the very frequent PVCs. Here we can see the morphology of this PVC. There is inferior axis, negative lead one, some kind of delta shape. It is possible epicardial origin. The first ablation was done 1 year before the workshop, and during the ablation there is the mapping of left ventricle, aorta, and coronary sinus. The best prematurity and pace map were documented in the coronary sinus, but the ablation was limited by high impedance and had only temporary effect. This is the workshop procedure, and first it has been done bipolar ablation on the place of the previous ablation. From one side it was the coronary sinus, and from other side something that is some kind of endocardial LV summit. After that, the new morphology was mentioned, and bipolar ablation was done in the upper septum between the both ventricle. In the follow-up time, during the follow-up, a small number of extrasystoles with different morphology, and a total burden of 5% were registered. And the next case, the next two cases will present my colleague.
The other fellow is Luca Kraba from Italy. We will show you next case.
Good morning, and thank you for this opportunity. So this is okay. So this is another case. Is an ablation with a multi-electrode mapping of atrial tachycardia using HD grid. So this is a female with thyreopathy, previous surgical closure of atrial septal defect by right atrial atriotomy, a previous RFA IVNRT, and on March 2021, an ablation of 3 types of ATs. The echo was remarkable without residual defect. So these are the types of supraventricular tachycardias that were ablated, atrial flutter, an AT from the right atrium, and a septal AT from the left atrium. The procedure was an acute success. But in the follow-up, we had the recurrence of a regular non-recurrence tachyarrhythmia. So another procedure was scheduled. During the procedure, we performed an insight map, which demonstrated the presence of a scar in on the lateral wall of the right atrium. During the EP study, we induced the clinical tachycardia that was an AVNRT. Here we can see the double AV node response phenomenon before the induction of the AVNRT. So we performed a slow pathway ablation that rendered the arrhythmia non-inducible, and we also applied an additional line of block between the scar and the IVC, causing the bidirectional block. The follow-up was without recurrence of the arrhythmia. Next case is an ablation of ischemic VT using a site and diamond tip catheter. So this is previous anterior myocardial infarction with the PPCI on LAD, an implantation of ICD in primary prevention, and since March 2021, he complained recurrent VT episodes. So in the echo, we demonstrated the presence of an aneurysm of anterior wall. And we programmed a procedure of ablation. This is the EKG in which we can see an anterior extensive necrosis. During the ablation procedure, we induced two morphologies of VT, one originating from the middle septum and the other one from the upper part of the aneurysm. We tried to entrain both arrhythmias, but in both cases we obtained the termination. We performed an insight mapping using HD grid. We found interesting late potentials, mostly in the upper part of the aneurysm, and we performed a circumferential ablation. In the follow-up, we didn't have any ICD intervention, but only few short duration NSVTs. Thank you for your attention.
So we have another presenter for Homolka cases. It's not international, it's Pavel Hala, it's Czech guy. It's our senior fellow.
Thank you. Good morning, ladies and gentlemen. Please, a different presentation. Yes, thank you. So good morning again. Please let me present a short reminder of last year's cases, which we presented live from Homolka Hospital last year. In April last year, we presented 4 cases, 2 paroxysmal atrial fibrillation ablations, one with laser balloon and one with pulse field ablation. One ischemic VT ablation done with RF, PF under the LVAD support. And we have a 4th case with permanent carotid filter implantation. The first patient was a 46-year-old man with paroxysmal atrial fibrillation, low CHA2DS2-VAS score, and a normal echo, mildly enlarged left atrium. This patient underwent pulmonary vein isolation using the HeartLight X3 laser balloon catheter. This catheter offers a more compliant balloon compared to the previous generations and offers us endoscopic image of the whole left atrium and allows us to use the rapid mode for automatic continuous motor movements of the laser beam. The whole pulmonary vein isolation lasted 31 minutes with a total time of ablation 12 minutes. There were no complications, and here on the right image you may see the view we had during each vein ablation. During the follow-up, the patient suffered recurrent short palpitations, and there was one short atrial fibrillation captured on Holter. So the patient was indicated for a reablation, where we found a gap reconnection in the left superior pulmonary vein. We ablated that, and we also saw a persisted isolation of all other pulmonary veins. The second patient was a 66-year-old man, again with paroxysmal atrial fibrillation with short history of this arrhythmia, normal echo, but the incessant tachycardia, atrial tachycardia during this procedure, which we expected to be a short, simple procedure, turned this case into a nightmare. We started the procedure with a pentanav catheter cartomap, and already in the beginning, we easily induced fast atrial tachycardia. We continued with a pulse field pulmonary vein isolation using the Farawave catheter, and then continued with atrial tachycardia mapping. We mapped on the septum, where we again applied the pulse field, and we slowed down the atrial tachycardia. But the arrhythmia continued, and we had to continue with mapping this arrhythmia in the right atrium. We found the earliest activation on the crista terminalis, which you can see on the activation map on the right bottom corner. And pulse field ablation here terminated this arrhythmia. However, during the follow-up, this patient had recurrent atrial tachycardias. He was put on amiodarone and was clearly indicated for reablation. This remap was done 10 months after the index procedure. We performed a carto remap. We saw all pulmonary veins with persistent isolation, and the atrial tachycardia was running independently on the PVs. Radiofrequency ablation on the roofline prolonged the tachycardia but did not terminate it. So we again continued with right atrial mapping. We mapped a large scar area on the lateral wall of the right atrium, and a connection line of 2 scars with RF ablation terminated the arrhythmia and led to non-inducibility. During the next 3 months of follow-up, the patient was without symptoms and no arrhythmia was captured. Case number 3 was an ischemic VT ablation. A 58-year-old man with history of myocardial infarction, low ejection fraction, who underwent Bioventrix hybrid ventriculoplasty and SICD implantation in the past. He suffered with slow ventricular tachycardia, which had to be terminated by amiodarone. His PAIN-SD score indicated high risk. That's why the procedure was done under general anesthesia and with assist device support by Impella. We created a cartomap of the left ventricle with pentanav catheter using the Visigo sheath and identified a large substrate in the LAD area. 2 VTs were inducible, and during these VTs, the hemodynamics was so borderline, even despite the LVAD support. We ablated with RF energy the late potentials, but this had no effect. We, in almost desperation, considered alcohol ablation, but then finally we again used pulse field ablation using the Farawave catheter in the apical part, and this led to non-inducibility. You see that only ventricular fibrillation was inducible with very aggressive protocol. During the follow-up of this patient, the patient is feeling fine. He had no VTs, no symptoms. We only captured some atrial fibrillation paroxysms. And the last case was a 73-year-old female with high CHA2DS2-VASc score after ischemic stroke in 2019 with persistent atrial fibrillation and atrial tachycardia after multiple ablations. And in this patient, we implanted bilaterally permanent percutaneous carotid filters. We used the fine needle implantation, which does not need any local anesthesia. And under ultrasound guidance, we implanted a 7 millimeter and a 6.5 millimeter filters in both carotid arteries. The patient was discharged on Pradaxa and Trombex for a limited time. And during the follow-up, we saw the patient 3 times with sonographic controls after 1, 6, and 12 months. The position of both filters was stable. There was normal blood flow in carotid arteries, and there has been no complication in terms of bleeding, thrombus, or stroke during the follow-up. So these were the 4 cases. I thank you for your attention, and I wish you a nice Congress.
Thank you very much for this overview. You see that procedures, even complex procedures, can be done safely, and they have generally good results. And we have to move on because we have some delay, but we have some time for discussion, so we are okay. And it's my pleasure to invite Paulus Kirchhof from Hamburg. And he will talk about ablation of asymptomatic patients with atrial fibrillation, whether there is a time to change guidelines. And you know that Paulus was behind this very important trial, East AFNet trial, and he will give you insight from this trial, and not only from the trial. Please.
Yeah, we have to get used to these hybrid meetings where you have jingles in between. Isn't it wonderful to see each other again in person? I'm so happy to be here, and thank you too for organizing this. Yeah, it's so great to get out of your hospital and out of your office in front of that Zoom screen again. And I want to take you out of the EP lab for a few minutes. Can you show my slides? They are on the... Perfect, excellent, brilliant. So these are my disclosures. In blue, the support that we had from industry and from public funders for the East AFNet4 trial. Now, when you think of atrial fibrillation, 30 years ago, people said, oh yeah, this is the benign electrical accident in the atria. But we know that it causes many complications, cardiovascular deaths, strokes, but also heart failure and acute coronary syndromes. Now, 70% of these can be reduced by oral anticoagulation, treatment of concomitant conditions, and to some extent, although we don't know for sure, by rate control. But there is still a gap of 30% of these complications that we cannot prevent with anticoagulation alone. You all know that we will have even better anticoagulants, or that we are likely to have even better anticoagulants in the future, and we've all moved from vitamin K antagonists to warfarin. But the principle that proved that anticoagulation helped was done with vitamin K antagonists, and now we have better tools. Now, when you look at rhythm control, we had established already 15 years ago, I'd say, that AF ablation is more effective than in preventing recurrent AF than antiarrhythmic drugs are. And these are 3 examples. Note that there is a big difference in recurrence rate whether you accept this so-called blanking period, and you can debate that for hours, but I do think it's more honest to report all recurrences of atrial fibrillation. Now, this is a bit more a detailed look. I got this detailed slide from Jens Nielsen from Denmark in the MantraPAF study, the first study that compared antiarrhythmic drugs and AF ablation as first-line therapy. First thing to note is that the safety of both treatment modalities is equal. And second, that AF ablation is better, yes, but it's not perfect. And I think we all know that, and we've seen that elegantly in the cases here that were performed by experienced operators in high-volume centers using the latest technology. We cannot prevent every recurrence of AF. The second thing that I want to highlight is, again, the blanking period. On the left, you have 2 survival curves, freedom of AF without blanking period. Yeah, I'm not sure whether I can point like this or like this. And you can see that the recurrence rates are high, and they mainly occur in the blanking period, the first 90 days. This is an antiarrhythmic drug trial. This is an AF ablation trial. And then, of course, if you ignore those first 90 days, you get much better survival without recurrent AF. The thing that I really want to emphasize in this context is that antiarrhythmic drugs work after AF ablation, and AF ablation works after antiarrhythmic drugs. So we can use both of them to restore and maintain sinus rhythm effectively, to come to a modern rhythm management concept. Why would we want that? Well, this is one of my favorite pictures. It's a picture of a healthy right and left atrium. It's from a goat because it's hard to take out these atria from people. And you can see what a beautifully organized, almost aesthetic structure it is. You would almost be tempted to put this on the wall in your living room. These are biopsies taken during standalone thoracoscopic AF ablations. And even though, of course, I cannot show you the whole atrium, you can clearly see the structure, even the color, the basic composition of atrial myocardium is damaged severely by atrial fibrillation. Atrial fibrillation damages the atria. And that simple observation led to the early treatment of atrial fibrillation stroke prevention trial that hypothesized that an earlier treatment of atrial fibrillation with rhythm management, rhythm control, would improve outcomes because it would be more effective and thereby also safer than the current delayed approach to rhythm control. And the hypothesis is very easy. Does early rhythm control therapy improve outcomes compared to usual care in patients with a recently diagnosed atrial fibrillation? Now, who was included in that trial? If you want to change guidelines, read inclusion criteria. Patients with a CHA2DS2-VASc score of 2 or more, so with comorbidities and with atrial fibrillation diagnosed within a year prior to enrollment. And they were randomized to either usual care, everything that was in the guidelines, anticoagulation, treatment of concomitant conditions, rate control, including rhythm control in symptomatic patients, or early rhythm control. And early rhythm control was very simple, rhythm control for everyone after randomization at the first presentation. And all patients were then followed up for up to 5 years. This was a typical cohort of all comers with newly diagnosed atrial fibrillation. Mean age about 70, a decade older than most of the ablation studies, a bit overweight, about 30% in heart failure, about 30% in persistent AF, about 40% presenting with their first episode, so really early treatment. Early rhythm control was delivered, and I'm really grateful to the people at the 135 sites, including the ECAM here and other sites in the Czech Republic, that they actually followed the protocol. Everyone, 19 out of 20 patients, got rhythm control therapy. The majority got antiarrhythmic drugs. The blue bars are the AF ablation bars. At 2 years follow-up, every fourth patient randomized to early rhythm control had undergone an AF ablation, of those who were still in follow-up then. So it was an important component, but it wasn't the main intervention. And usual care consisted, as expected, of rate control only first, and then the symptomatic patients, about 1 in 7, which is what you would expect, received rhythm control over time. Now let's look at this in a bit more detail, because that is the clinical practice that I think we should practice now. The number of ablation was very high at the start and continuously increased. And those are the patients that had recurrences of atrial fibrillation on antiarrhythmic drugs, and they underwent AF ablation. Now, you've all seen the primary outcome, but it is an essential part of this study, so I'll tell you. Early rhythm control given to everyone at the time of randomization, so as early as possible in the trial, reduced cardiovascular complications by 20%. Every fifth stroke, every fifth cardiovascular death, every fifth ACS, every fifth heart failure hospitalization was prevented. Each component of this composite outcome was numerically lower in patients randomized to early rhythm control. This is probably the most important part of the paper and my presentation. I do firmly believe that the main reason why early rhythm control was successful in that trial is that it was delivered safely. We had fewer strokes. This was part of the outcome. We had numerically fewer deaths. But of course, we had complications of rhythm control therapy. There were tamponades, there were access site complications of ablations, there were bradycardic events, mainly bradycardic, by the way, of antiarrhythmic drug therapy. So these things do not go without harm. And I think it is very important, probably the most important thing, that we deliver rhythm control safely to our patients. Now, I was asked to talk about symptoms, and we had about 30% asymptomatic patients randomized in East. This slide, it's a bit small, shows you that the type of rhythm control was identical in asymptomatic patients and in symptomatic patients. So there was no difference in the type of rhythm control used in the different forms, in the different symptom scales. And importantly, these graphs show you the survival curves for each of the 3 symptom strata: error score 1, asymptomatic; error score 2, moderately symptomatic; and error score 3 and 4, highly symptomatic. There was no interaction. The treatment was equally effective in asymptomatic and symptomatic patients. This is only a sub-analysis, of course, but as we included symptomatic and asymptomatic patients, I think it's fair to conclude that we should offer rhythm control to asymptomatic and symptomatic patients. And of course, that is a big change to what we were trained to do. Now, I was also, sorry, this is the, I just made this slide because we had the paper accepted yesterday, so there is a typo in there. The same is true for AF patterns. So we compared patients with first diagnosed AF on the left, paroxysmal in the middle, and persistent on the right. And there was no interaction between the treatments and the AF pattern. So the persistent AF pattern patients benefited in the same way than the paroxysmal. If you look at the curves, you see that the curves separate a bit later in those with first diagnosed AF. An interesting thing, and may have to do with the fact that there were fewer recurrences in usual care. But importantly, there was no interaction, and interestingly, there was a higher need for ablation in patients with persistent AF. So we had about every 3rd patient still in follow-up who had undergone an AF ablation when they entered the trial in persistent AF. So that I'd like to summarize systematic early rhythm control therapy using either antiarrhythmic drugs or AF ablation. And that is really something that you can discuss with your patients or do based on your local availability of treatments. Reduces AF-related major complications by 20% on top of anticoagulation and optimal therapy of concomitant conditions. The safety of early rhythm control was key to this outcome. And I think that is something to keep in mind when we perform our everyday procedures, when you go back to your EP labs. You want to make sure that AF ablations are safe. And I think that rhythm management should now consist of both rhythm control and rate control as the standard. And we should move away from this old debate of rate versus rhythm. We should use rate and rhythm control treatment in all patients with recently diagnosed AF and concomitant cardiovascular conditions. And then we can achieve optimal clinical outcomes. Thank you.
Arguments for early VT ablation, which is Thomas Deneke from Bad Nauheim, but actually I think this is recorded. So please, if you can send us on the screen his presentation.
Hello everyone, my name is Thomas Deneke. I'm from the Heart Center Bad Neustadt, and I'd like to share with you some arguments for early VT ablation. And when we discuss early, we have to consider what early really means. So it is supposed to be before the usual or expected time, which in the literature actually includes multiple settings. So early is considered in some publications after multiple VT episodes, after a single VT episode despite one or no antiarrhythmic drug, after a first VT storm, after first ICD intervention or shock, which we would call secondary prophylactic, after a first sustained VT episode, or before any VT episode, so primary prophylactic or true prophylactic VT ablation. Some other studies actually indicated to be within 30 days after documented first VT episode. This is more related to early referral. So if we look into the current recommendations and guidelines, what we have to consider is that there has been a downgrading of ablation of after first VT episode for catheter ablation to a 2B level of evidence A recommendation. So actually only a 1 class A recommendation in the ischemic population would be recurrent VT despite antiarrhythmic drugs. And the same is true for non-ischemic as well. So actually in the recommendations, if we follow the recommendations, we would do VT ablation later than after a first VT episode. If we look though into the reality in Europe, this is completely different. There has been a survey which was published a couple of years ago by Roland Tiltz, a survey in European centers, what the therapy is after a first VT episode in a patient with an ICD. And comparing ischemic cardiomyopathy to non-ischemic cardiomyopathy, what you can see is in the ischemic population, most centers would actually do a VT ablation early, so after a first VT episode, 60%, whereas in the non-ischemic cardiomyopathy, it's only 1/3 of the patients, 1/3 of the centers that would actually consider VT ablation after a first VT episode, because the arrhythmogenic substrate is much more complex and the results are less good as VT ablation in the ischemic population. Looking at some of the trials that have focused on the optimum time point of ablation, and I have to admit this is not the true reason why these studies were performed, but what you can see is that in the SMASH VT trial, the inclusion criteria was early VT ablation was actually an ICD with at least 1 appropriate therapy. So these patients usually had at least 2 ventricular arrhythmia episodes. The SMS study, which was performed in over 100 patients randomized to catheter ablation or conventional treatment, if a patient had a single episode of a VT or VF, so this would be considered after a first VT episode, and ablation was usually done before ICD implantation. You can see in these cases there was no difference in the outcome in regard to freedom from VT or mortality in the SMS trial. And the Berlin VT trial is also a study looking at early ablation in patients necessitating an ICD, which was considered either to be preventive, which would be a ventricular arrhythmia patient who has had 1 episode of VT or ventricular arrhythmia, or conventional. And as you can see, there is a trend towards a higher freedom from VT in the ablation group, but no effect on mortality. And actually, this was non-statistically significant in the Berlin VT trial. So actually, we're as wise as before. And I think there are only a couple of studies that really will help us to answer this. This is again data from the Berlin VT study, and I indicated to you that there is a trend towards reduction, numerical reduction of sustained VT or VF episodes after appropriate ICD therapies in this specific cohort of patients receiving, having at least 1 ventricular arrhythmia. So what I think is a strong argument for early ablation is actually the Partita trial. It was a complex trial which was first presented from Paolo Della Bella at the Together VT 2021 meeting. And as you can see in the Partita trial, which was a randomized controlled trial, comparing the efficacy of VT ablation after a first ICD shock. So these are usually patients who already have had, who've had lethal or fatal ventricular arrhythmia necessitating ICD implantation as secondary prophylactic patients. And you can see that over the time course of 3 years, the patients were enrolled over a long time, but after and followed up after ICD implantation for their first ICD intervention before they were randomized either to ablation or no catheter ablation. As you can see, only 10% of the patients actually received an appropriate ICD shock for VT at a follow-up of nearly a median follow-up of nearly 3 years. And 22% of the patients had ventricular tachycardia episodes. So that means that really only a minority of patients were actually randomized in the study. And when you look in the phase B, where patients were randomized, only 47 patients out of these over 500 patients actually reached the second phase. What is interesting to see, though, is that in these cases, after a first ICD shock, patients who were randomized to ablation were doing dramatically better compared to patients not receiving catheter ablation. And the trial was early terminated because there was a close to 100% probability that VT ablation is superior in relation to mortality and heart failure hospitalization. So there is an indication that actually, if you do VT ablation early, which means after a first ICD intervention, VT ablation may also reduce mortality and have a beneficial effect on the outcome of these patients. What I think should not be mixed up in this regard is that that there are some studies indicating that early referral, so the time point from the first VT episode to the time point where ablation was done, was tested. And there was a recent publication of a meta-analysis of 3 non-randomized trials comparing early versus late referral for VT ablation. And early would mean that usually within 30 days after a first documented VT, or VT despite antiarrhythmic drugs. So it's again a mixture, but in the overall cohort of this meta-analysis, patients did dramatically better in regard to complications, had less complications, and had when they were referred early, and patients who were referred late had was associated with a higher VT recurrence. So I think this concept really stands out for a general management concept for ventricular tachycardia patients. And I just want to briefly address that we have a concept where we have a network of cooperating centers that can admit or transfer the patient anytime they want to, and we have a dedicated VT unit, which is a multidisciplinary unit with an interdisciplinary team allowing heart failure treatment, structural cardiac abnormality treatment, and all the things that we need to safely guide the patient through VT ablation, which is only a minor part of rhythm stabilization on the one hand, and may have a slight benefit on mortality. So in conclusion, ladies and gentlemen, the optimum time point of VT ablation is still unclear. Early admission and transfer for VT ablation appears more effective and less complications. VT ablation after a first ICD detected episode is beneficial in regard to rhythm control and maybe, as indicated in the Partita trial, also on mortality. But what we don't know is what about true prophylactic VT ablation. And I think we're just learning to identify those 10% of patients who receive ICDs and then produce ventricular tachycardia, which imaging may be important, and modeling of and virtual heart technology. Thank you very much.
So the next presentation is by Massimo Grimaldi from Bari, and he will answer a very important question, whether it's safe and when to stop oral anticoagulation after ablation for atrial fibrillation. Please.
Thank you, Peter. Thank you, Joseph, for inviting me in this really amazing meeting. And I really brief this friendly atmosphere. It's wonderful. Thank you. And your title is really important for our patients, because many patients want to stop anticoagulation, and many patients want to undergo ablation in order to stop anticoagulation. Let's go to see what happens in the real world. This is a Japanese registry from Okamura, and as you can see, after 1 year, 43% of patients stop anticoagulation. After 2 years, 56% of patients, they stop anticoagulation. When we split this cumulative, when we split this cumulative observation, we can see that when the Charts-Vasquez score is very high, the discontinuation is lower, luckily. We have, with Charts-Vasquez 4 and 3, around 35% of patients that stop anticoagulation. This is important that Charts-Vasquez, all patients should stop anticoagulation, but we have that 25-30% of patients, they continue anticoagulation. And the most interesting group is Charts-Vasquez 1. On Charts-Vasquez 1, we will reflect a lot later. This is one more observation of this study. It is amazing that people that continue oral anticoagulation has more episodes of stroke and TIA than people that stop anticoagulation. Why? Because in this group, we have much more people in high Charts-Vasquez score. This is more damaged heart and vascular disease. These are worse patients. So this is the reason that we have more stroke and TIA in oral anticoagulation continuation group. Of course, we have a bigger difference in measured bleeding with oral anticoagulation, worse patient, very high level of event rate, and all cause of death go worse in oral anticoagulation. Again, oral anticoagulation in this group are the patients with a higher Charts-Vasquez score. So, does it mean that oral anticoagulant discontinuation wins against continuation 3-0? No. The real message from this study is that the underlying heart disease wins against oral anticoagulation 3-0. So what I want to tell you that oral anticoagulant is very important, but is even more important the underlying heart disease of our patients and risk factors, of course. In this study, coming from China, we have a meta-analysis with more than 11,000 patients, and you see that there is a trend in favor of stop on oral anticoagulation when we want to prevent thromboembolic event, but it is not statistically significant. There is a huge statistically significant advantage in measured bleeding, of course. But again, when we analyze all these papers, you see that in oral anticoagulant discontinuation, there are a lot of people with very low Charts-Vasquez, 0 or 1. In oral anticoagulant continuation, there are the worst patients. So this is the reason for this kind of results. In this nice paper review coming from Jonathan Piccini, we have the first paper I showed you and 2 more papers. You see that the oral anticoagulant discontinuation is very high. is very high, also in CHA2-VASc 2 or more group of patients. And correctly, Jonathan Piccini tells us, pay attention, because the stroke risk is not only related to our ablation procedure. Even if we do a perfect atrial fibrillation ablation procedure, this is only one of the phases of incidence of stroke. The stroke prevention is very important also, of course, the adherence to oral anticoagulant, left atrial appendage occlusion, and above all, the substrate, the risk factors. This is, I think, the most important. This means that stroke is not son of atrial fibrillation, but probably stroke is a brother of atrial fibrillation, and this view of our patients. And we are studying something about folate cycle, and we observed that in patients with heterozygosis or homozygosis for MTHFR genotype, we have in homozygosis the maximum fibrosis. When we do an ablation, we find that more than 70% of points are under 0.05 millivolt. And heterozygosis is in the middle. And this patient very frequently have associated a PFO or a ostium secundum defect. What I want to tell you is that this is only one of many systems in our body that interact each other in increasing the stroke risk. So again, the stroke is not the son of atrial fibrillation, but is a brother. Hypertension is another aspect. So we should think to our patients at 360 degrees. In fact, in this paper, looking at high-rate atrial high-rate events, we see that we have some stroke also in patients without atrial fibrillation, but with high CHA2-VASc score. So in this patient, they didn't record any atrial fibrillation episodes, but they had stroke. So even if our ablation is perfect and the patient has no more atrial fibrillation, if the CHA2-VASc score is very high, I mean very high, I mean more than 3, probably 2, 3, pay attention, because even without atrial fibrillation, the risk score is not 0. Oral anticoagulation, of course, is very important when the F burden is higher and higher is the CHA2-VASc score, much less important in low CHA2-VASc score. So focus our attention on 0 and 1 CHA2-VASc score. In this kind of patients, according to this nice paper, we also have the highest percentage of success rate. When increase the CHA2-VASc score, the success rate of atrial fibrillation ablation tends to reduce. We have more recurrence. And in this nice paper coming from Luigi di Biase group, you can see that in this paper analyzed 3,700 patients. In patients with 0 and 1 CHA2-VASc score, the rate of ischemic stroke is only 0.3%. It is not related to stop anticoagulation or continue anticoagulation. There is no difference. In this group, with CHA2-VASc 2 or more, when we stop anticoagulation, we have an increasing of risk of more than 1% a year. So when with CHA2-VASc score is more than 2, and we stop anticoagulation, we give to our patients every year 1% of risk of stroke more. And I think this is an important message. According to guideline, because Joseph and Peter asked me when stop. According to guidelines, at least 2 months is mandatory for all patients. After 2 months, what we have to see? We have to see the stroke risk profile of our patient. CHA2-VASc 0, okay, for sure, stop. CHA2-VASc 1, we can stop, but we look also to renal disease, according also to arterial risk score. This is a very interesting score because It put inside the proteinuria and GFR less than 45 of our patients. And this is one more risk, the renal disease. And in all our patients, we do an imaging technique before or during ablation. We do the intracardiac echo, we do the transesophageal echo. And the chicken wing morphology, as this very nice paper from Luigi, the chicken wing is the lower risk morphology. Cauliflower and cactus are higher risk. And we also see the flow velocity. So we can also consider the flow velocity when we do our intracardiac echo. Next future. Next future, we have 3 ongoing trials. We have the Ocean, that is comparing rivaroxaban versus aspirin after ablation. We are this study that is comparing dabigatran versus no anticoagulation. And I bet in these 2 studies that in high CHA2/VASc we will not get any kind of result. And probably in patient with CHA2/VASc 1, 2, probably we can get something. And the third one is the option study. It's interesting because it is going to evaluate the left atrial appendage occlusion versus oral anticoagulant. But in the field of oral anticoagulant, there is a very important news. This drug is asundexian, is a direct factor 11 blocking agent. It is very interesting. 2 weeks ago was published on The Lancet the dose-ranging phase 2 trial with 20 milligrams and 50 milligrams, and in more than 700 patients, this drug demonstrated a superiority to apixaban in major bleeding. So we have a new drug that is able to stop, to block the thrombosis, what we need, but is able to don't stop the hemostasis. And this is a very interesting drug for the next future. So, concluding my talk, dear colleague, if we want to save the brain of our patients, we can stop the oral anticoagulant after 2 months, not before, in CHA2/VASc 0, and in CHA2/VASc 1 patients. Better if the morphology of appendage is a chicken wing, good velocity of flow from the appendage, and no renal disease. I checked for hypertrophy, but I didn't find any work very statistically significant for the left ventricular hypertrophy, so I don't write it, but I checked for many papers. If we want even a better protection, I think that we should do the atrial fibrillation ablation as soon as possible, when indicated, as Paul told us just before. This is a very crucial point, as soon as possible. Strict control of risk factors, and many papers now are working on this, lifestyle change of our patient, especially the obesity, and adherence to oral anticoagulant when indicated. Thank you for your attention.
Thank you, Massimo. And okay, thank you, Massimo. And we will move to another talk related to optimal anticoagulation for VT, for patients after VT ablations. So actually, this is Luigi Biase from New York. And actually, it's recorded, so please show us the presentation.
Hello, I'm Professor Luigi Biase from the Albert Einstein College of Medicine Montefiore Hospital in New York. I'm very excited to present this year at the Prague Rhythm 2022. I would like to thank Professor Kautzner for the kind invitation. Unfortunately, I will not be there in person, but next year I promise I will. And the task that I've been assigned is what should be the optimal anticoagulation therapy after VT ablation. And these are my disclosures. As a background, you know that the number of VT ablation and the efficacy of ventricular arrhythmia has improved dramatically in the last decade. We do more procedure, and we all know that periprocedural stroke is a devastating complication of any left-sided electrophysiology procedure, with an incidence that goes from 0.8 to 1.8%, maybe more if underreported. Although the intraprocedural risk of systemic thromboembolic events is reduced using intravenous anticoagulation, heparin, or bilivardin, the risk of strokes and periprocedural strokes remains in the post-procedure period. In addition, the risk of subclinical cerebral event detected on brain magnetic resonance imaging is associated with potential adverse long-term neurocognitive effects. And what's the pathophysiology of the systemic thromboembolism in left ventricle ablation? Well, of course, we undergo an endocardial denudation with a subsequent risk of thrombus formation at the ablation site. There is an hypoperfusion injury of the cerebral vessels. There is a coagulum and char formation in the catheter tip. There is a low flow status during recurrent VT. In many patients, poor LV function and the local myocardial standing. All factors that improve and favors systemic thromboembolism and cerebral injury. Post left ventricle ablation, antiplatelet or oral anticoagulant data is limited and is often extrapolated from the AFib ablation experience. The duration of post-oral anticoagulation is variable in different studies. If I think about two big VT studies, the SMASH VT had 4 to 6 weeks of oral anticoagulant. The Thermocol VT with the RF lesion more than 3 centimeters with 3 months of oral anticoagulation. And although the periprocedural stroke risk in both these clinical trials was minimal, the benefit of initiating oral anticoagulation should be always weighted against bleeding risk in the immediate post-procedure period. To date, there is no randomized study evaluating different anticoagulation strategies following left ventricle ablation, but the one I'm going to present today. From the ablation, atrial fibrillation ablation standpoint, we learn in this non-randomized paper on big numbers, 2,000 patients, that interrupted warfarin bridge with low wake molecular heparin was not a good strategy when compared to uninterrupted warfarin, where we had no TIA stroke and very little minor bleeding when compared to the interrupted strategy. And then the COMPARE trial, which is a randomized controlled trial, where patients undergoing AFib ablation were randomized to interrupted Coumadin versus uninterrupted warfarin, show the superiority of the uninterrupted oral anticoagulation for the ablation of atrial fibrillation. But still, this is only in the atrial fibrillation field. And the COMPARE trial set the stage for all the NOAC that we use today, rivaroxaban, apixaban, dabigatran, apixaban, and edoxaban, to show that uninterrupted oral anticoagulation is the way to go to reduce periprocedural stroke and minor bleeding complication, including hematoma, when compared to bridge or stopping this medication. Can we apply this concept to VT ablation? I think we can. Also, the presence of brain MRI during AFib ablation has been a problem with interrupted anticoagulation, and the AXAFA trial that I was able to be the co-PI with Dr. Kirchhof here in the panel today, we recently published an extension of the AXAFA trial looking at brain MRI, and we show very well that using uninterrupted anticoagulation, acute ischemic brain lesion detected by MRI was not associated with a cognitive function at 3 months after ablation. In addition, lower MOCA scores before and after ablation were associated with only with older age, highlighting the safety of AFib ablation on uninterrupted oral anticoagulation with apixaban in this specific trial. Another trial that was not randomized, that set the stage to the randomized trial I'm going to present, is this paper on circulation, where brain emboli after left ventricular endocardial ablation was presented in this PVC VT ablation, where out of 119 patients with eligible 62 patients, they went for RV only and LV only ablation with a lot of LV only. You can see how many were transeptal, how many were retrograde, the majority, 10. And this is the baseline conclusion with almost presence of this brain positive findings in almost 50% of the patients. The author concluded that patients undergoing LV endocardial ablation are at significant risk of cerebral emboli, and the significance of which is unknown. In more than half of patients, this may develop cerebral emboli with LV endocardial ablation, a much larger proportion that's seen in AF, despite fewer ablation lesions and ablation to high flow cardiac chamber. But all these patients were not on uninterrupted anticoagulation before the procedure, and not all of them after the procedure. So future research is critical to understand the long-term consequence of these lesions and to determine optimal strategies to avoid them. This set the stage to what we published last year in 2021, the stroke VT trial. The study hypothesis is that periprocedural direct anticoagulants can reduce the risk of cerebrovascular event, both clinical and subclinical, with the MRI in patients undergoing left ventricle ablation as compared to aspirin only alone, which is what the standard of care was for VT and PVC ablation. So this was a multi-center randomized controlled trial of patients undergoing LV arrhythmia ablation, either PVC or VT. Stratified randomization at this institution between the two interventions. Patients were excluded if they had a cerebral vascular accident, a CVA or a TAA in the last 3 months, if they had non-compatible MRI, and they had contraindication to aspirin or DOAC. 260 patients were randomized. Out of these, 246 were at the end randomized to direct oral anticoagulation versus aspirin. The study drugs administered 3 hours after hemostasis was achieved. Direct anticoagulation, aspirin only. 11 patients crossover from aspirin to DOAC after the primary endpoint, and all patients underwent MRI brain 24 hours and 30 days post-ablation. All patients underwent in both groups. And let's look at the results. The VT ablation was done endocardially or epicardially as deemed necessary. IV heparin with an ACT of 360 was utilized. Epicardial mapping and ablation was performed as needed. Vascular closure device or figure of 8 stitch was usually routinely, and the study drug was administered 3 hours after hemostasis was achieved. Within 24 hours after the ablation and 30 days after a cerebral MRI was done, and images were adjudicated by an independent blinding radiologist. I don't want to go through the whole methodology for the MRI. Clinical outcomes, the primary outcome was the study primary endpoint was the incidence of stroke or TIA or MRI detecting asymptomatic cerebrovascular events at 24 hours and 30 days follow-up. Secondary outcomes of the study were procedure-related complication, a composite of any vascular complication, pericardial complication, heart block, thromboembolic event, excluding stroke or TIA, and in-hospital mortality. An intention to treat analysis was performed that includes all patients. They assigned trial groups only if they successfully completed the procedure. 14 patients were who were randomized but did not complete the study were excluded from the analysis, and data were compared utilizing the Strata software. These are the baseline characteristics of the patient. As you can see, no major difference. This was a randomized trial, including the antiarrhythmic medication. And these are the procedural characteristics. You can see that the majority were transeptal when compared to retrograde, and that epicardial ablation was performed in 25-30% of the cases. The endpoints are very clear here. You can see that in the aspirin group, there was a higher number, statistical significant, of TIA and stroke when compared to the NOAC utilization, as well as the presence of cerebral event at the MRI at 24 hours and 30 days was statistical significant within groups. No major difference into the complication, and the hospital mortality was found. And to summarize the result, you can see here the transient ischemic attack, the stroke, the 24-hour MRI, and the 30 days MRI. In blue, the NOAC use. In yellow and orange, the aspirin use. So there was a difference in the outcomes between PVC and VT ablation. Overall, no significant difference was observed in terms of stroke or TIA in patients undergoing PVC or VT ablation, but MRI detecting asymptomatic cerebrovascular event at 24 hours was significantly higher in patients undergoing PVC ablation when compared to VT ablation, 25.8 versus 14%, and this was statistical significant. And this can be expected because more patients undergoing PVC ablation had a retrograde aortic approach, 58 versus 34. However, no difference was observed at the 30 days follow-up, 14 versus 11.4%. And again, these were the predictor of the cerebrovascular event, where you can see that the aspirin use was the strongest predictor together with ejection fraction. Which are the limitations of our study, where the limitation is that there was a crossover rate of 8.9% in the aspirin group, the lack of an aspirin load, the lack of long-term follow-up and quality of life on the neurocognitive evaluation. The optimal duration of oral anticoagulation post-ablation still remains unclear, but the role of uninterrupted oral anticoagulation in left ventricular ablation, especially where arterial and epicardial axes are always involved, could be challenging. It's unclear if dual antiplatelet therapy after left ventricular ablation will be equivalent to DOAC, although we know from the AFib ablation that that's not true. And retrograde aortic approach is associated with a higher risk of systemic thromboembolism, and DOAC use post left ventricular ablation significantly improves the risk of systemic thromboembolization. So, ladies and gentlemen and colleagues, I would like to conclude that post-procedural DOAC use significantly reduced the risk of stroke and TIA and asymptomatic brain magnetic resonance imaging lesion compared to ASA or to aspirin. Retrograde aortic approach is associated with significant increase into the risk of systemic thromboembolism, and low ejection fraction, prolonged ablation time, and aspirin use increase the risk of ischemic thromboembolism in these patients. Thank you very much for your attention.
Hello and welcome. My name is Gerhard Hindricks from the Heart Center Leipzig in Germany, and it's a privilege and a pleasure to participate in the meeting in Prague, which is almost a historic meeting that Josef Kautzner and colleagues organized for so many, many years. The task of my presentation today is to share with you some of the updates of one of the biggest and maybe one of the most important projects that are currently going on in the field of risk stratification for sudden cardiac death after myocardial infarction. So I would like to inform you and give you an update where the PROFIT project stands. And I would like to do this also on behalf of Nikolaos Dagros, friend and colleague, and the key brain behind the whole project. The aim of PROFIT is a personalized prevention of sudden cardiac death after myocardial infarction improvement. We know that risk stratification for sudden cardiac death is currently solely based, almost solely based on left ventricular ejection fraction, and that is depicted on the left side of the slide here. We focus on the patients with ejection fraction of less than 35%, and they receive an ICD that results in a significant overtreatment, particularly over the last couple of years when medical therapy, remodeling, heart failure interventions and heart failure therapy has significantly improved. The sudden cardiac death rates went down and down and down, which is a huge achievement, but it resulted in the fact that we may have a significant overtreatment. We implant too many ICDs in order to protect appropriately in the patient population with an ejection fraction of less than 35%. On the other hand, we have the forgotten ones, the lost ones, as I call them, patients post-myocardial infarction with an ejection fraction of more than 35%. And for these patients, there is no protection for sudden cardiac death prevention. We simply leave them alone. And if you consider that most of the victims of sudden cardiac death exactly come from this population with more than 35%, when we think about absolute numbers, then it's a situation that needs to be resolved and that needs to be improved. On the right side of the slide, you now see the aim of the PROFIT project to change that, to reanalyze current knowledge and current data from the field of risk stratification for sudden cardiac death, regardless of ejection fraction, with the aim to develop a risk predictor that identifies high-risk patients and identifies low-risk patients. And the high-risk patients should then be appropriately protected. This is the strategy of PROFIT. PROFIT is a public-sponsored by the European Commission scientific approach where 24 consortial partners from 10 European countries contribute to. And it's actually a three-step project, three-step approach for the re-evaluation improvement of for risk stratification for sudden cardiac death. And the first step of the PROFIT strategy was to re-evaluate and reanalyze available existing knowledge and existing data and implement that in a risk prediction model. So we collected in a worldwide approach more than 200,000 adjudicated patients, clinical characteristics such as age, sex, NUA class, medication, renal function, and atrial fibrillation and other characteristics, including biomarkers, and also including data from MRI imaging data to develop a risk prediction model. In the third step, so first step is re-evaluation of existing evidence. Second step is development of a risk predictor. And the third step is to evaluate the risk prediction model in two prospective randomized clinical trials. PROFIT reduced for the patients with ejection fraction of less than 35% and PROFIT preserved. In the reduced arm of the randomized trial, we will identify with the risk predictor high-risk patients, and these high-risk patients will not participate in the trial. But low risk and less than 35% will then be randomized into optimal medical therapy and optimal medical therapy plus an ICD with a goal to evaluate the effects of ICD on total mortality. The strategy is, I would say, vice versa in the PROFIT preserved trial. In PROFIT preserved, we will identify patients with an ejection fraction of more than 35%, and according to the new risk prediction model, having a high risk for sudden cardiac death. And these high-risk patients, the high-risk, currently unprotected ones, they will undergo a randomization to optimal medical therapy or optimal medical therapy plus an ICD to evaluate the effect of the ICD on top of medical therapy. And the low-risk patients, they will not participate in the randomized trial. The key inclusion criteria was presence of a myocardial, diagnosed myocardial, improved myocardial infarction, or an ischemic cardiomyopathy with a left ventricular ejection fraction of less than 50%. Exclusion criteria were cardiac resynchronization therapy at baseline. We analyzed 19 data sets from Europe, the United States, and from Israel, including 224,898 patients. And you see on the left side the data sets and the left ventricular ejection fraction distribution. And as you can see, we had data sets with significantly reduced ejection fraction and also data sets with only mild to moderately reduced ejection fraction, that the whole spectrum of ejection fractions after myocardial infarction is represented. In phase 1 of our analysis, we developed a prediction model that used all variables from these 225,000 data sets, except of the CMR data. So we focused on everything we had, ejection fraction, plus up to 80 clinical variables for development of a risk prediction model. We analyzed the data set for left ventricular ejection fraction alone, and then for various contributions of clinical characteristics with the approach to improve the prediction of sudden cardiac death. In the phase 1, we applied 4 statistical models, 2 traditional statistical models and 2 models that included machine learning and a neural network, deep learning. In phase 2, and I will focus on phase 2 of this analysis in a minute from now, we updated the model from phase 1 with the CMR variables. This slide depicts the results of profit of this analysis of phase 1 for the non-ICD patients. We had data sets from ICD patients, from SCATEF, from MADIT, and from other data sets. And we had data sets from patients without an ICD on board. And this is the analysis you see here for the 4 different models, and for left ventricular ejection fraction, the area under curve at 12 months for the prediction of sudden cardiac death. Here are the different data sets. A meta-analysis was done for the area under curve at 12 months for left ventricular ejection fraction. It was 0.61, which is moderate. It's not a good risk predictor for sudden cardiac death. However, the statistical models that included various types of analysis and various modes of enrichment of the prediction model with clinical characteristics showed that there was only a slight improvement in the risk prediction for sudden cardiac death. Honestly, I expected this result for left ventricular ejection fraction, but I was really surprised and thought it's particularly interesting that clinical characteristics improve risk prediction so little. If we look to the ICD populations, it gets even worse. On the left side, again, you see the different data sets. You see the analysis for area under curve at 12 months for the 4 models, plus left ventricular ejection fraction. On the right side, the meta-analysis for the AUC at 12 months. And for left ventricular ejection fraction, it's 0.53. 0.5 is flipping a coin. 0.53 is almost as good or as bad as flipping the coin. And the 4 different statistical models did not substantially improve that. This was a surprise, and I really did not expect that. There's no space for disappointment in science, so I was not disappointed, but I was really surprised. We then added the CMR data sets, and as you can see, it's 1, 2, 3, 4, 5, 6, 7 different sources where we collected more than 2,000 CMRs adjudicated for sudden cardiac death, or the proxy of sudden cardiac death. To my knowledge, the biggest data set that was analyzed in this setting so far at any time. We analyzed the core infarct size and the gray zone, and we applied different methods, all approved in the literature for the definition of core infarct size and gray zone, and all data sets underwent a homogenization process for the definition of scar and gray zone. Now I would like to share with you the first results of this analysis. This is an analysis based on the following settings. Core scar was defined with a 3 standard deviation method, gray zone defined as 2 to 3 standard deviations. Here you see the data sets and the area under the curve. And as you can see, there was a substantial improvement for the risk prediction for the non-ICD group of 0.75. However, in the ICD group, it's still below 0.6, which was also surprising for us. What will be the next steps for the further analysis and the further building and setup of the risk prediction model? Data collection is complete now. We will develop one model for the full range of left ventricular ejection fraction values and validate this with a leave one out data set approach. We will analyze and compare all 5 quantification options for scar and gray zone measurements, and then assess the performance, AUC, and calibration at 12, 24, 36 months and select the best performing model. And as the next step, we will assess the sensitivity, the positive predictive value at various thresholds, 10% highest risk, 20% highest risk, and so on, and select the optimal method. So for the moment, with this update on the PROFIT project, I would like to conclude CMR re-evaluation in PROFIT is now complete. The first results indicate improvement of predictive performance for sudden cardiac death by considering core scar and gray zone quantification. The comparison of different methods and thresholds for scar and gray zone will add further information, and we will come back to you with an update of the results for the PROFIT project soon. Thank you very much for your attention.
Although we are a bit late, we can cut some time from lunch time and we can have discussion. So any questions to any of the speakers or comments?
Guys?
Thank you very much. My name's Tav Danjal from Coventry. I've got 2 questions. The first question to Thomas Deneke and the second question to Luigi Biase, both absolutely fantastic talks. Question to Thomas regarding timing of VT ablation. I think globally we are moving in the right direction in terms of where we see VT ablation fitting in the timeline of patients receiving therapies. The Partita trial, I certainly liked the design of that trial. In terms of the analysis, my question, Thomas, is that the composite endpoint of death and recurrent hospitalizations as a result of VT was significantly lower in the VT ablation group. Now, how much of that was driven by non-cardiac causes of death in the standard care group? I think there was a significant number of deaths in the standard care group that were non-cardiac related, i.e. cancer related. So how was that composite endpoint? What did that analysis look like if we just focused on cardiac deaths? And just the second part of that is there was amiodarone avoidance in this study. Amiodarone was avoided certainly in the ablation arm. In the standard care arm, was amiodarone also avoided?
Well, thank you very much. A very important question. And first of all, thank you, Josef and Peter, for inviting me. And sorry for not being able to make this. So as you know, the Partita trial is not yet published. And so we don't have a definitive analysis of all that. Non-cardiac causes were a major driver of the composite endpoint. But in essence, there was also a high degree of cardiac deaths in the control group. So I think it is fair to say that actually VT ablation has had an impact on the death counts in the group. So again, it's really hard because we don't have the exact publication yet, which is still under review in circulation. So as soon as we have that, I can come back with the answers. But right now it's just a matter of, I think it's both, but it's mostly that VT ablation actually related to a lower rate of cardiac deaths as well.
Luigi, fantastic presentation on the use of oral anticoagulation post-VT ablation, a trial that has long been demanded. Can I ask you in terms of timing of the oral anticoagulation post-VT ablation when there's no classical indication for oral anticoagulation? How long should we continue oral anticoagulation for in these patients and what's the justification for that?
Yes, thank you very much for the question. And again, thank you, Joseph, for the nice invitation. And hi, Peter, and hello to everybody. Unfortunately, I'm missing Prague in this time. So, I mean, this trial, really showed that, when we do left-sided procedure, especially retrograde, I would say, although there was no power there, aspirin alone, which is what we are supposed to give after the procedure, is not enough, and you need to have an anticoagulant. And probably that anticoagulant needs to be started even a few days before the procedure. We have no data on that, but that's my practice right now. I say at least for 2 weeks post-procedure, I use the oral anticoagulants. It's fair to say that the NOAC have changed, the compliance to the patient, because in the past, if I had to start Coumadin, a big issue to be therapeutic and everything. Now with the NOAC, you can start the medication, have 2 weeks of oral anticoagulant, and stop that after the procedure. Because for the VT ablation, we're not worrying about, unless there is an indication for anticoagulation of any other issue. I think differently from AFib ablation, in VT ablation, we are not giving the anticoagulation for the reason of the recurrence, but because of the manipulation in the left chambers. Therefore, I guess 2 weeks is okay. Now, many people will say, well, I've been giving, aspirin only, I've done WPW. Well, I think this trial proved that, what is in our mind is not what the numbers say. When you do a study and you put numbers in a spreadsheet and you collect, you can see that there were a lot of TIA or positive brain MRI. These are patients that probably, have called the physician, say, oh, post-procedure, I have a strong headache. I had an headache that didn't go away. Or, these are not major strokes. These are minor strokes. These are positive findings at the brain MRI. Therefore, I feel that, the use of oral anticoagulants really has solved our problem.
Josef, can I have a question? Can I ask Massimo a question?
Go ahead, Thomas.
Okay. Massimo, great presentation. I really enjoyed it. And do you know where actually these 2 months come from? I looked through a lot of studies indicating that actually it's either 3 months or 1 month anticoagulation post-ablation when you stop as early anticoagulation after AF ablation. I didn't find any study evaluating 2 months and compared this to any other study. So did you find anything on that?
Hi, Thomas. Thank you for the question. You are right. The guidelines, they speak about beyond 2 months. But you are right, there are no comparison studies. So you are perfectly right. But the recommendation are 2 months, and we are suggesting 2 months after ablation. And we can stop in all CHA2/SWASC 0. We stop all CHA2/SWASC 1, but not people with renal disease or with no good morphology of appendage and a low flow from the appendage. But about the when, how to stop, because Joseph and Peter asked also about when, you are perfectly right. There are no data available with statistically significance, any kind of data. You are perfectly right.
It's very interesting discussion about how early we can serve the ablation. Actually, if we can protect the substrate formation, and it's clearly related to anticoagulation, right? So as early we can serve and we can ablate, we probably can just save the substrate, and actually we can treat a little bit less diseased population, not only less symptomatic, but less diseased. The question is for you, Massimo, I'm a little bit always provocative, okay? So if you have a patient or human being, no patient, human being, no any AFib, no any nothing, but CHA2/SWASC 5, okay?
Okay.
So this is the argument for what? For just expecting something to put for example, like sub-Q monitor or something, or just leave it, or what?
In this very high-risk population of CHA2/SWASC 5, also when you don't have atrial fibrillation, the study with monitor we already have, also you don't have any atrial fibrillation burden, you may have stroke. So when the substrate is very damaged, you may expect stroke with or without atrial fibrillation. And this is very important. As I told you, as soon as possible, and I didn't know about talk of Paul, but that is message. Of course, we can't stop the progression, but we can slow down. Because if we have a genetic, if we have the age that go ahead, we can slow down the damage. We can't stop at all because we are not, we can't do everything, but we want to slow down. Probably Paul wants to add something.
Yeah, Paulus, please.
I think that, can I speak like this? Or, yeah?
Probably you are connected,
okay.
right? So.
Okay. So first I'd say Massimo gave a very balanced talk. And it's difficult because there are very strong opinions in that field of stopping anticoagulation, and there is not that much data. And all the data that we have comes from observational studies, and we all know that we are trying to be good doctors, and that corrupts every observation analysis. Very simple.
Yes,
but we have several trials, including the ESUS trials, including heart failure trials with DOACs and warfarin that have tested high CHA2/VASc populations on anticoagulation or aspirin. And there is no real stroke prevention effect of the anticoagulants in that scenario. But I think we also have to accept once you have atrial fibrillation, we have atrial cardiomyopathy. And that is not fully reversible by rhythm control therapy, certainly not by AF ablation, where we induce damage to prevent further damage, but also not with other means. I found that the most intriguing article or study that I've read in this regard was Laos 3. And I think we will move towards doing even more because the risk is there. So Laos 3 was remove the left atrial appendage and anticoagulate. And we may have to test that for occluders. And I do think that we will offer early rhythm control and continued anticoagulation because in the end, stroke is one of the most feared events from the perspective of patients. Bleedings are bad for us because we have to hospitalize patients, we have to treat them, but they are typically transient. And stroke is one of the 3 most feared events when you talk to patients. They're afraid of cancer, of dementia, and of stroke, and then of accidents maybe. But so I think we will actually move towards doing more rather than doing less.
But actually, I think it is very important you stated the appendages, because now we have no emancipation of appendage closure strategy. And I think we need to wait for the champion and catalyst trials, which are indicated by Prague 17 trial, which we actually the Czech trial, and it's the very first randomized trial showing like at least non-inferiority incorporated NOACs, right? So I think, well, it's a lot of, like rumor, and I think we need to clean up if the ELA indication of ablation, okay, or this strategy, how to understand the CHA2/VASc scoring or some risk scoring, it's affecting us, right? Pierre?
Peter and
or Luigi?
Yeah. So
Luigi, please.
This is a very complicated topic. I agree with Paulus. Massimo gave a very balanced presentation. I think a dichotomous change has arrived with the NOAC, because when we have patients with successful ablation on warfarin, if you have a CHA2/VASc of 2 and you have a patient that is on warfarin for 20 years of their life, warfarin was exposed to a lot of, variation and risk of bleeding, very high. So I think the risk of having recurrent AFib versus having, an inappropriate INR was probably not fair. Now that we have NOAC, I think, yes, high CHA2/VASc, probably we should stay on anticoagulation. But the provocative question of Peter was, okay, then we should put on, if you have a successful ablation and you don't have more AFib, and today we have iWatch, Cardia, if the patient document not having any more AFib, and we still need to give anticoagulation, probably we should give anticoagulation to patient in sinus rhythm with a CHA2/VASc of 5. And, there has to be here something that we need to understand. And the second point is, how many of you would believe in because we have Cardia, iWatch, post-successful ablation, CHA2/VASc of 2, would you use in a patient that can check his pulse or check his rhythm frequently? Would you use a pill in the pocket anticoagulation management?
Yeah, but I think we cannot draw back time. We don't have the fountain of youth. A patient who had atrial fibrillation and then underwent an AF ablation and has an AFib burden of 0, for the sake of the thought argument, has a different atrium than a patient who never had atrial fibrillation.
Yeah, maybe also ablation makes some changes in substrate. There might be improvement in velocities in appendage, shrinking the size of the atrium. So there are some indirect data that suggest this. So maybe this Chatzwas cannot be applied to this population because they haven't been tested in such population anymore. So it's more complex. But on the other hand, we know that patients with higher Chatzwas, even if they don't have atrial fibrillation, they have a higher risk of stroke. So
it doesn't become to zero due to anticoagulants. And we should not forget that. It's never zero risk, even under anticoagulants. So the question is, rather, do they improve their prognosis by using the anticoagulant or not? And it's not so clear either. I mean, those with high CHADs in the AF at least.
I think we need good studies on this topic, because otherwise there will be never answer in this question.
And that is one of the few instances where the surgeons were actually faster than us. They did LAOS 3, and 90% of those patients who all were randomized to left atrial appendage removal or not were anticoagulated. So, and the appendage removal reduces stroke rate on top of anticoagulation, similar to early rhythm control.
Paulus, I completely agree with you, but I have to tell you, we had very hard time. We tried to publish a paper, which is now published, on the use of low-dose apixaban, which we call half-dose, post-periprocedural implant of Watchman, and until 6 months. And after 6 months, instead of staying on aspirin for life, staying on low-dose apixaban for life. And you know, the comment about, oh, you put a closure device to avoid anticoagulation and you keep taking anticoagulation. And the idea is not that, is that patients are non-compliant with anticoagulants. Low dose work as good as strong dose when you have a closure device and you have an arthropathy. But I agree with you, that's probably the way to go, but the people against this type of approach, closure and anticoagulation, are enormous, are very difficult to task.
Well, maybe I have a last question for Paulus. Do you expect that, can you speculate if in the East trial was more patients who undergo ablation in this active arm or early treatment arm, the result could be even better? Or you expect now, with the advent of pulse field ablation, which can make ablation safer and faster, that this can really influence guidelines? And there was nice discussion during EHRA by John Cam, because he was talking about how guidelines are always lagging behind the clinical practice. And in many areas, it could be in guidelines, even though we don't have a lot of randomized trials, but overwhelming practice shows something different. So what is your opinion about these things?
Oh, it's a brilliant question. I think my first observation is that people are moving towards early rhythm control. When you look at the numbers of ablations and the proportion of patients who are treated with rhythm control, it has increased since 2020. And I think that's good. That's correct. It shows that people actually adopt new concepts, and they don't necessarily need a guideline writer to encourage them to do that. Now, the question whether AF ablation has a special role in early rhythm control is one that I would love to answer. And we are actually working with our statisticians. We've done that for over a year now. We hope to be able to report the differential effects of AF ablation and antiarrhythmic drug therapy at the ESC, but I can't promise you, because it's a really complicated statistical thing. You've heard Gerhard talk about profit. These statistics are never, they don't give a definitive answer, but we want to do them as well as possible. But I do think we need more trials. It is probably now, with the current safety and efficacy of AF ablation, is a good time to start a controlled outcome trial of AF ablation versus usual care. And I would hope that we can get a good or even better outcome than what we saw in East.
Well, I think that we probably need to repeat all the studies, right? After PFA, right?
No, there is a... I don't think we need to repeat all the studies, but you do need more than one study to convince a guideline group. I mean, if I have actually advocated to get a focused AF guidelines update on rhythm control. And I do think, for example, the Canadians have done that. So there are different reasons, not only the science.
Okay.
But yes, yeah.
Well, I would like to thank to all speakers and to all of you for coming. We have now lunchtime, and don't forget to come back at 2:30, and we start the afternoon session. There will be, again, lectures and then live cases.
Thank you very much.
Bye, Thomas. Thank you.